Good afternoon and welcome to the next edition of the Rheumatology Nurse Practice Google Hangout series. We're super excited that you're able to join us today. A couple of housekeeping notes before we get started is Rheumatology Nurses Society. We are a nonprofit association focused on educating nurses in the rheumatology. We have a core curriculum, we have the scope and standards of practice, we are an accredited ANCC provider, and we also have board certification through the ANCC for rheumatology nurses. And we'd like to invite you to visit our website at rnsnurse.org, which you'll see at the end of the session here for more information. This session will be recorded. This is a 20-minute session that's focused around challenging cases in rheumatology. Our faculty today is Linda Grinnell-Merrick, who is a nurse practitioner at University of Rochester, and Carrie Beach, who is a BSN RN. They're both also sit on the board of directors of the Rheumatology Nurses Society, and they're very, very excited today to share with you some of these challenging cases. The challenging cases are really based out of an initiative that we have called Rheumatology Nurse Practice. And Rheumatology Nurse Practice is a publication that we send out as a peer review publication that you can get continuing education for. And the current edition is on how drugs work, the differences between novel small molecules and biologics in the treatment of RA. And to get this is a free resource that we offer to members and non-members alike. You can visit our website and sign up for that. And we'll be more than happy to mail you a publication as well as you'll have access to the online publication. So today we're talking about some challenging cases that relate to this. And there's a few ways if you would like to ask questions, if you're watching the live version of the broadcast, is of course you can go to the link, and this is one of those funky links you got to look at, and I'll read it out to you. It's goo.gl/slides/BU78SR. You can also, on Twitter, use the hashtag RMP17, and you can also text your questions to a Google Voice text line. So you can text using your cell phone to 267-689-8495. So let's get started today. This is a quick 20 minutes. We have 18 minutes left to go. And we'd like to turn it over to Carrie and Linda. Thank you for being with us today.
Thank you, Kevin. Hi, my name is Linda Grinnell-Merrick, and I'm presenting a case of a lady that is dear to my heart, and I know as nurses we see this frequently. We get very attached to some of our patients. So this is a 62-year-old female with seropositive, very deforming rheumatoid arthritis. She is both CCP and rheumatoid factor positive, and she was diagnosed back in the 1970s. And you know, she has other medical history, obviously, that goes along with this. She has secondary Sjogren's. She's had a lot of osteoarthritis that goes along with her inflammatory arthritis. Both of her shoulders, she's had to have rotator cuff repair. She's had debridement going back as far as 2003 and again 2012. Hyperlipidemia, because of course our patients have a lot of other comorbidities associated with their diseases. Some acid reflux disease, hypothyroidism, and again she's been plagued with her reflux disease this past year. And her medication list is quite long. Again, not unusual for our patients. You know, she's on sulfasalazine. She's been on that for quite some time. Takes some Vastin. She's been on etanercept, and we'll look at that a little bit closer in a few minutes. She's been on that. She's been on that for quite some time. Omeprazole, levothyroxine. We have her on diclofenac gel for her joint pain. Some naproxen, Docetaxel, calciferol and calcium, omega-3 she takes, aspirin, she takes some vitamins, some ascorbic acid, and then she uses a nasal spray for some allergies that she has, mostly seasonal. So, you know, her RA, she's always been a pleasure. She comes into clinic and she's just one of these sweethearts, always a pleasure to have and to see. Her disease had been stable on etanercept for 19 or more years. It'd been a long time. And then out of nowhere, as last spring, she comes in and she's calling us and she's saying, you know, I'm flaring, my joints are swollen. She came in a couple times. I drained her knees, or attending doctor had to drain her knees. So, you know, we kept treating her with some steroids. So we decided in the spring to just make a change, and we moved her over to adalimumab. But she continued to have flares. She kept needing to have steroids. She again came in. We had to drain her knees again. She just wasn't responding. So we switched her from prednisone to methylprednisolone, hoping that was going to help us. So we started at a fairly high dose, 24 milligrams a day for a week, and slowly was tapering that down, and she was taking her naproxen. But that didn't work very well. I think we'd done that kind of early midweek, and by that weekend she was seen in our emergency department, came in with 10 out of 10 pain in her left knee. The knee was warm, had lots of swelling. She came in on crutches. She couldn't bear any weight, and could barely move the knee when she was seen in the emergency room. So Carrie, at this point, what do you suspect? What do you think is going on with this patient? And I'll stop there and I'll let you answer.
Okay. What do I think? I mean, it sounds like obviously the etanercept was not working for her any longer. It sounds like her rheumatoid is flared, but it's kind of surprising that it was just the one knee that took her into the ER. That was you know, a little bit different.
Mm-hmm. And you know, so patients like her who've been on therapy for a very, very long time, you know, how commonly in your own practice have you seen it where suddenly the biologic just loses its efficacy and it's not working for the patient anymore?
Very common, very, very common. I was actually surprised this patient had been on the etanercept for almost 20 years. That's very rare. So, I mean, we hope that's a great response, but I would say that's rare. So we see it pretty frequently. We're having to switch biologics.
Yeah, I know. It was unusual. I can't believe she lasted that long on that one, on the one medication. I've got a couple of patients like that. Always amazes me. And when you see patients like this and you're having to counsel them, you know, when they're flaring, you got to counsel them through their flarings and even helping them, maybe changing meds and convincing them, you know, how do you kind of go through that?
Sure. So I think it's really important to just reassure these patients that this is normal, that there are a lot of times with RA, it's trial and error. You know, we have to find what works for you. What works for one RA patient obviously doesn't work for others. So I always try to reassure them about that, and that there are a good number of medications out there to, you know, switch to. So I always tell them, I say, you know, they keep coming out with new medicine, so it's rare for you to get to the bottom of the barrel.
Yeah, hang in there. I always tell them we haven't found the right cocktail maybe yet, you know.
For you, right.
We have to change the recipe up.
Yep.
Yeah. Good. Well, let's keep going with our case. Oops. So she's in the emergency room. And she, you know, there was a couple of things that came up that I don't think we were even aware of here in the office when we'd seen her. She was complaining, obviously, that she wasn't just, not only the knee was bothering her, but her hands, her fingers were bothering her. They were swollen. She was also having milder discomfort in her shoulders, her neck, and her ankles. And then what came out, which was new for me, and I didn't realize that she had not shared it, even though she'd been in the office on numerous occasions, you know, so we could drain her knees, was that her daughter had suddenly become ill earlier in the spring before all of this happened, and she was now wheelchair ridden. And though mom was working, and you know, my patient continues to work, she also, I think I lost my slide here. Thank you. She became the primary caretaker for this daughter and was having to lift her and move her around, which you can imagine how stressful this was for her. And this lady has so many deformities. I'm amazed that she's doing this so well. Anyway, but she denied that she bumped her knee, no fevers. She had no history of gout, but then she did mention that as a child, she had been diagnosed with juvenile gout prior to her diagnosis of RA. So that was an interesting piece of information we got when she was in the emergency room. So while she was in the emergency room, they gave her IV Solumedrol. They repeated the tap to the knee, you know, did an arthrocentesis. Fluid was sent off. And when she came in to see me, and I looked up the fluid, I was surprised to see that she had calcium pyrophosphate deposition, which is pseudo-gout. So I thought, oh, finally, we have the answer. I know what's going on. So I started her on colchicine. And then she comes back, you know, within a week, she's flaring again, spoke with our attending doctor. Now what do we do? So we switched her to infliximab. Again, still nothing was helping her. She still was needing a lot of high dose steroids, which isn't obviously the best way to manage this. We increased the colchicine to twice a day. Still, that wasn't working. So then we came up with this idea. We switched her, we discontinued the infliximab, and we started her on a daily regimen of anakinra. So this was kind of a novel thought, and probably people are going, why would you make that choice? But we had been using it with patients with gout that was refractory to treatment, and it has been used in RA. It's in daily injections, so we thought, let's give this a try. Amazingly, within 1 month, her joint symptoms began to respond. It was absolutely amazing. I wasn't getting calls from her every day. I wasn't having to drain her knees. She came in about 3 months in. Absolutely no swollen joints. She was looking the best I'd seen her look in a very, very long time. We were able to start decreasing the methylprednisolone, but we've kept her on the sulfasalazine. We've made no changes to the colchicine at this point. And now she's scaring me a little bit because she is going in to have right shoulder replacement. I think she might be going in this week or next week. So I am holding my breath and a little worried about that. But the caveat here is that with this medication, because it's a short half-life, we're not holding it for very, very long.
How long are you holding it for? Just curious.
So we've decided, again, I'm holding my breath. We've decided to just hold it a couple days pre-surgery and a couple days post-surgery, as long as her incision is healing really well. So I'm really hoping this is going to prevent any type of flare, and keeping things going. The interesting part about all this, and then we can talk about this more, as she's gotten better, at the same time, I found out that her daughter is also improving. She's no longer in her wheelchair. She's not requiring daily care. So I think that the two things kind of happening simultaneously has been interesting.
Absolutely.
Yeah. So this is interesting. What does anakinra play in today's RA patients? And I can answer for me, and then I'll let you answer, Carrie. It's not a medication that we're using. I didn't even know how to order this medication or know how to get this medication to the patient. We'd used it a few times with patients in the hospital, I think, as I mentioned, who were kind of refractory, had gout that was refractory to treatment. And then I've used it on one other RA patient that we just couldn't seem for, and whether it's a daily dosing that's helping them. But share with me what you've been seeing, Carrie, in practice. I know we talked about this a little bit beforehand.
Right. So we actually were just talking about this morning in our practice. We do not currently have any patients on anakinra. I was trying to look back and see when the last time was. It's probably been 10 years, I would say.
Wow.
And I can remember specifically 2 patients, both males, and both had Still's disease. So that's initially what we had used it for. Like I said, I don't have any current RA patients on it. It's interesting. I had never heard of it being used for the refractory gout. So that's
yeah.
See that.
It's probably off-label, so nobody should run out and do this or make recommendations for it. I just think sometimes when you just don't know what else to do,
right,
just kind of reach and try to see what you can do.
Yeah, absolutely.
So, yeah, and I think I was kind of hinting on to this. Daily stressors are our patients' lives and flares, and losing efficacy of treatment. As I ponder this and I think about this, I really feel, and you could share with me maybe some of the stories you've seen in your practice, that I found it interesting that after 19 years on a stable treatment and doing well, and maybe she hadn't been doing as well as she was telling us, and that's always true. Our patients aren't always 100% want to tell us exactly what's going on. Maybe they're not ready to admit it, but I found it interesting that she started to flare as badly as she did as her daughter was really ill. And certainly started to see, well, she was getting better. Her daughter was also getting better. And I'm sure you probably have stories you can share, or have you seen this in your practice also?
Yeah, of course. I think anytime there's a increased amount of stress, that seems to coincide with a flare of RA. The decreased efficacy in medicines too. I think, I don't know what the mechanism is, but definitely stress plays a role on your immune system. And so we see it all the time. And I think with this patient in particular, the fact that not just emotional stress, but I mean, she had to have been taking on a lot of extra physical stress too. I mean, she's 62 and having to do a lot more physical work for her daughter. So I think it, you know, it makes sense that she would flare.
Right. And I do think her starting to feel better. I do think changing the meds and doing everything we've done, I do feel that as her daughter was getting better, I think that played a role too in how she was feeling. I try to ask my patients that, you know, when I see them and they're flaring, you know, what's going on in your life? Is there something happening that we need to know about? So I know you kind of were sharing this case and the use of anakinra with some of your colleagues. How do you think this might have been managed differently if this was in your clinic, let's say?
I guess probably not with anakinra. I mean, I definitely think changing biologics as you did, even, you know, the etanercept to the adalimumab to the infliximab, perhaps we would have tried maybe a different, I mean, you went with the anakinra, perhaps we would have gone with a different route rather than an anti-TNF. So I'm trying to think, rituximab is a big one that we use here. Just kind of depends on the patient, but it's interesting that the anakinra actually worked and so quickly. I mean, a month response time is pretty impressive.
It is. And I do think for this lady, maybe what we were missing was the underlying pseudo-gout. And I'm not certain if she wasn't responding that great to the steroids, which you would have expected. I do wonder what that role played with this patient having some of that pseudo-gout. But we'll see how this goes. I don't know if we'll get 19 years out of this one or not, but we'll see how that goes for her.
How was she with doing the daily injections? Was that?
Oh God, that's a good question. You know, that when I, you know, the physician who kind of been managing this case, and she brought up anakinra, and I'm like, isn't that daily injections? You know, and how's she going to do, you know, do you think she'll go for that? This patient really was hurting so badly, she really didn't care. She was all in, you know, just whatever it takes. I can't keep doing this. This has been so difficult. So she was all in. We'll see how it goes. If she's feeling better over time, if, you know, if she'll still be all in and agreeable to this. At this point, she's doing really well and managing the injections every day without any difficulties.
That's great. That's really
yeah. I think our patients will do what they need to do. You know, if we approach it.
I say that all the time to them. They're, you know, when I'm doing a teaching for self-injectable, like, you know, this may burn or this may hurt for a second or 10 seconds or however. And they're like, do you have any idea what I deal with on a daily basis? That is nothing compared to, they want to feel better. So most of them amazes me, more than willing to try whatever we throw at them.
Yeah, they really do. They do want to feel better. And if it's, and she's done injections before, so I don't think that was so horrible for her, even though it's every day.
Right. And you gain trust. They trust you. So I'm sure she trusted whatever you told her would be best.
Thank God it worked.
Awesome. Well, we're coming up to 20 minutes, which is we're keeping these new Google Hangouts pretty tight on time. And we do want to thank you for joining us. Carrie, Linda, do you have any last minute comments or thoughts?
No, I love this case. I'm sure people have some great cases out there. And, you know, if you want to share cases with us or you have some ideas of cases you'd like to see presented, shoot us a message.
Right. That's right.
Yep.
So awesome. Well, thank you both. And be sure to visit our website, rnsnurse.org. You can see there on the screen. If you go to rnsnurse.org/RMP, you can sign up for the free edition of the Rheumatology Nurse Practice. Our next broadcast is going to be noon on Tuesday, May 23rd. So you'll watch for our announcements on Facebook and social media and email for these upcoming broadcasts. I also want to share, Linda is our president-elect, and she's also our conference committee chair. And we have our annual conference coming up August 9 through 12. And it's our 10th anniversary conference. So we're so excited, and we'd like to invite you to go to our website, Check out the information about the conference. The session topics are phenomenal. And we're celebrating the Heroes of Caring, which is another initiative that keep an eye out on Facebook. We have something special launching here in a couple of weeks for you. So we have our annual conference. We would love to have you check out our resources on the website. Once again, I'd like to thank Carrie and Linda for your time today, and we appreciate everyone who's viewing. Have a great day.
Thank you.
Bye.
Thanks, everyone. Bye.